Hello friends, this is Nishant Gautam, Associate Professor from the Department of Pharmacology. So today we will continue your same chapter, that is the fibrinolytic and antiplatelet drugs. We will study its second part, and as we know this chapter belongs to our second unit, that is pharmacology of drugs acting on cardiovascular system. So the fibrinolytics, also called as the thrombolytics. So what are the fibrinolytics? Fibrinolytics are the agents or the drug having the potency or the capability to lyse the thrombi or the clot, to recanalize the occluded blood vessel, mainly the coronary artery, are called as the fibrinolytics. These are the therapeutic rather than the prophylactic and work by activating the natural fibrinolytic system. So, fibrinolytics mainly we are utilizing as a therapeutic agent because the fibrinolytic system is already there in our body to maintain the balance between the clotting and the anti-clotting system. Here we have classified some of the fibrinolytics or the thrombolytics, like as the streptokinase, Antiplase, Urokinase, tissue plasminogen activators like the Alteplase, Tenecteplase, and then the Tenecteplase. Then let us discuss with the site of action of different thrombolytics. The plasminogen plasmin system is there. By with the help of this chart, we can easily understand the different site of action of different thrombolytics. Two systems are there. One is the extrinsic and another is the intrinsic. At the extrinsic side, what happens? The plasminogen get converted into the plasmin, which further facilitates the conversion of insoluble fibrin to the fibrin fragments, that is become the soluble type of the fibrin fragments. Here in the extrinsic system, the streptokinase, urokinase, alteplase, and the recombinant tissue plasminogen activator and Tenecteplase acts on the plasminogen and works as a activator. And from the intrinsic side, factor 12, activated factor 12 and Caligari and the tissue plasminogen activator acts as an activator for the conversion of plasminogen to the plasmin, which further facilitates the conversion of insoluble fibrin into the fibrin fragments, that is the soluble fibrin. And then what happens? Hemostatic plug of platelets formed at the site of injury of blood vessel is reinforced by fibrin deposition to form a thrombus. Once repair is over, the fibrinolytic system is activated to remove the fibrin. The enzyme responsible for the digestion of the fibrin is a serine protease, that is the plasmin generated from plasminogen by tissue plasminogen activator, which is produced primarily by vascular endothelium. The plasminogen circulates in plasma as well as remain bound to fibrin. The tissue plasminogen activator selectively activates fibrin-bound plasminogen within the thrombus, and any plasmin that leaks is inactivated by circulating antiplasmins. Then fibrin bound plasmin is not inactivated by antiplasmin because common binding site for both fibrin and antiplasmin. The tissue plasminogen activator is itself inactivated by plasminogen activator inhibitor 1 and 2. Then let us discuss about the drugs one by one. The first drug is streptokinase. Streptokinase was the first thrombolytic agent approved for the clinical use and it has been used extensively. Streptokinase is a purified bacterial protein isolated from lensified group C strain of beta hemolytic streptococci. This produces a conformational change that exposes the active site on plasminogen that cleaves ARG 560 on free plasminogen to form the plasmid. Due to its bacterial origin, streptokinase stimulates an immune response and the production of antibodies in humans. Because circulating, that is, neutralizing antibodies can inactivate the drug streptokinase cannot be re-administered for at least 6 months. The another choice of the drug is urokinase. Urokinase is a protease enzyme obtained from human urine and is now produced by cultured human kidney cells. Urokinase is a direct plasminogen activator and degrades both fibrinogen and fibrin. The half-life of urokinase is 20 minutes and urokinase has more fibrin specificity than that of the streptokinase. Then the third choice of the drug is Alteplase. It's a tissue plasminogen activator and is a recombinant tissue plasminogen activator. Alteplase is a poor plasminogen activator in the absence of fibrin is the key point of this drug. Tissue plasminogen activates fibrin-bound plasminogen several hundred-folds more rapidly than it activates plasminogen in the circulation. The Alteplase and the marketed name is Activase is produced by recombinant DNA technology. The currently recommended regimen for coronary thrombolysis is the use of this Alteplase and the 15 mg intravenous bolus is followed by 0.75 mg per kg of body weight over 30 minutes. 0.5 mg per kg up to 35 mg accumulated dose over the following hour. And the additionally, Tenecteplase is also a recombinant form of the tissue plasminogen activator having a longer half-life. Now, the fourth choice of the drug is Tenecteplase. The Tenecteplase is the genetically engineered substitution mutant of native tissue plasminogen activator. Has the higher fibrin selectivity, slower plasma clearance, that means the longer duration of action, and resistance to inhibition by the plasminogen activator inhibitor 1. Then the Tenecteplase is the only fibrinolytic agent that can be injected intravenous as a single bolus dose over 10 seconds, while Alteplase requires 90-minute infusion. Further, this feature makes it possible to institute fibrinolytic therapy immediately on diagnosis of ST segment elevation myocardial infarction. In short, we can say STEMI therapy. Then let us discuss about the hemorrhagic toxicity of thrombolytic therapy. The major toxicity of all thrombolytic agent is hemorrhage, which results from the two factors. The first is the lysis of fibrin in hemostatic blood at site of vascular injury, and the another is the systemic lytic state that result from systemic plasmin generation, which produces fibrinolysis and degradation of other coagulation factors, especially the factor 5 and the factor 8. In addition to this, intracranial hemorrhage is by far the most serious problem. Hemorrhagic stroke occurs with all regimens and is more common when heparin is used. Now, the therapeutic uses of these fibrinolytics are used in acute myocardial infarction to treat the deep vein thrombosis, in the pulmonary embolism, and in the peripheral arterial occlusion cases, in the strokes, and mainly in the ischemic stroke. We are using the drug Alteplase as a fibrinolytic agent. So, finally, discuss with the contraindications of fibrinolytics are categorized under the two categories: absolute contraindications and relative contraindications. The absolute contraindications are the prior intracranial hemorrhage, known structural cerebral vascular lesion, known malignant intracranial neoplasm, ischemic stroke within 3 months, suspected aortic dissection, active bleeding or the bleeding diathesis. And the last is the significant closed head trauma or facial trauma within 3 months. And if you will see, the relative contraindications are the uncontrolled hypertension, in that the systolic blood pressure more than the 180 mm of the Hg, or the diastolic blood pressure more than the 110 mm of Hg. The another relative contraindication is the traumatic or prolonged CPR or the major surgery within 3 weeks. Recent, within 2 to 4 weeks, internal bleeding is also be there in case of the pregnancy and also active peptic ulcer. The current use of warfarin and the international normalized ratio more than the 1.7. Then the toxicity of these fibrinolytics can be made overcome by the use of the inhibitors of the fibrinolysis. The example of that drug is aminocaproic acid. The aminocaproic acid is a lysine analog that competes for the lysine binding site on plasminogen and plasmin, blocking the interaction with plasmin with that of the fibrin. Aminocaproic acid is thereby a potent inhibitor of fibrinolysis and can reverse states that are associated with excessive fibrinolysis. For intravenous use, a loading dose of 4 to 5 gram is given over 1 hour, followed by an infusion of 1 to 1.25 gram per hour until bleeding is controlled. Then no more than 30 gram should be given in a 24-hour period, whereas rarely the drug causes myopathy and muscle necrosis. Another choice of the drug as the inhibitors of fibrinolysis is the tranexamic acid, also a lysine analog that, like aminocaproic acid, competes for the lysine binding site on plasminogen and plasmin, thus blocking their interaction with that of the fibrin. The mechanism can be made understood with this simple diagram where it is showing the blocking of their interaction with that of the fibrin. The FDA approved oral tranexamic acid tablet for the treatment of heavy menstrual bleeding in 2009. When it is used for this indication, tranexamic acid usually is given at a dose of 1 gram 4 times a day for at least 4 days only. So that's all for the day. We will continue the same chapter in the part 3. Till that, have a nice day and thank you.